Dear colleagues, welcome to this edition of the EAUTV. My name is Alberto Briganti and I have the honor to moderate this session today with friends and colleagues. It's a true pleasure for me to introduce our guest today, Alicia Morgans, who is a very well-known medical oncologist working in Boston, Dana-Farber, Dr. Karim Touijer, who is a urologist based at the Memorial Sloan Kettering Cancer Center in New York, Dr. Briers, who is actually representative of patients on behalf of Europa Uomo. So welcome you all here today. It's a true pleasure for me now to touch upon different topics about advanced prostate cancer. And over the last days during this meeting, we have seen nice data and a new release of guidelines and many debates about different topics which are clinically relevant for us dealing with prostate cancer, not only physicians, but patients as well. So let me start just with Alicia. Thank you again for accepting our invitation. We have seen a very nice session on something which is truly important for us. The initiative, which has been led by Lancet in coordination with the EAU, about prostate cancer, which has several aims and which might be indeed useful not only for physicians but for patients as well, trying to understand which are the priorities and the future of prostate cancer care. Can you please tell us something about it?
Sure. So I think this was such a wonderful accomplishment and also pretty challenging. There were about 40 authors who came together from a global group, and Nick James from the UK led the group. And we spoke about trying to understand where should prostate cancer care go in the next few decades, thinking 15 to 20 years even down the line, and reflecting on where we are. And there were four main pillars, and these included global urology and global care of prostate cancer, as well as screening and detection and how we can make that a more equitable practice, localized disease and advanced disease, and how we ensure that we get the best outcomes across all of these disease spaces. But one of the most striking things, I think, to come out of this commission is that it is expected that the population of patients with prostate cancer diagnoses will probably double in the next 15 to 20 years, really around screening and detection of disease prior to becoming metastatic in low and middle income countries. And also because we as a cancer care and medical community are taking better care of patients who have other comorbidities. And so people are living longer. It's really an expectation that we're going to see the numbers significantly climb.
Has this been based on personal ideas or communications, or did you do like a screening of the literature? How did that work?
This was really a screening of the literature and some mathematical modeling that is making these expectations. And I don't claim to know the details of how those numbers were arrived upon, but they were definitely using statistical methods and statisticians to help us.
Excellent. I think this has been a fantastic initiative, and we do hope indeed that many more will come in the future with the idea indeed of having a clue of what will happen in the field of prostate cancer in this regard. There are many topics I would like to touch upon with you beyond the Lancet Commission. Karim, I just want to involve you in this discussion about recent data that you have just presented during the meeting. There has been a big echo about in generally speaking, the role of lymph node dissection, the combination with imaging, and of course you are the PI of this study, which you presented as a game changer. So can we please elaborate a bit more on the study that actually you just presented a few hours ago?
We're very pleased to present for the first time at the EAU 2024 the updated results of our randomized trial looking at extended versus limited pelvic lymph node dissection. There are a couple of aspects to this trial. One is with regards to lymph node dissection, and one is conducting large randomized clinical trials in surgery. To the second point is at a single institution, we were able to enroll 1,500 patients in 5 years in a randomized trial of a surgical technique.
Which is quite unique, you know.
It is unique, and it's one of the largest trials in surgical oncology. And it's unique in the sense because we blurred the line between clinical practice and randomized trial by this model that was developed by Peter Scardino and Andrew Vickers of clinically integrated trial. If you standardize all the steps and there is one specific aspect in the surgical technique or in the surgical care of prostate cancer that you want to test, you will still run the trial, and the only randomization happens only in that very specific aspect. Otherwise, your practice, your data gathering, and everything is the same, which means that today, and Alicia knows very well, that if you were to run a trial of 1,500 patients, we're talking about several millions of dollars. And so this format of clinically integrated the trial in our practice, where we're practicing medicine at the same time practicing academic medicine, is low cost formula. And we have published on that, and happy to share with everyone interested the way to do that. I think it will allow us to have more randomized trials and things that are important questions for us as surgeons, and also to do it in a collaborative way at low cost, because the price of running a trial of that magnitude can be completely inhibiting that.
This is absolutely great. You touch upon a great topic on the feasibility of running trials in surgery, and we have seen way fewer trials in our setting as compared to radiation therapy or medical oncology. Before going to the results of your study, I just want to involve you in this discussion, which is the importance of patient involvement and how much you feel important to be part of prospective randomized trials.
For patients, we understand how important clinical trials are, and we know that if we want to get better treatments in the future, we will have to do and go for the data to be able to include them in guidelines. So we need this evidence, and the evidence can only come from well-organized and well-executed clinical trials. But we do understand that beyond the clinical trial, there are two real worlds. There is the real world of the clinicians. They are not all as good as the clinicians who do the clinical trial. So they will not all be capable of executing what is coming out of the clinical trial with the same quality. And the other real world, that is the patient's world. Because in a clinical trial, you select patients. And it depends on the kind of the trial, how big this selection is, how many inclusion, exclusion criteria there are. Because in the end, in metastatic cancer, you are testing the best of the worst. You're not selecting them all. And this means that we lack now information after the clinical trial on what a real patient will have. If the patient fulfills the criteria to be in the clinical trial, we have a good idea what his outcome will be.
And Alicia, sorry, to get the point, how much real-world data kind of resemble what happens in trials? Is there a big difference between the real world and trial results?
You know, that's such a great point, that there's a major difference, particularly in some domains, between effectiveness in the real world and efficacy in a clinical trial. And I think that, to your point, particularly in a surgical setting, I would think that that gap may be wider. And so it's incumbent on you and on the EAU and the training programs to ensure that the surgeons actually are able to perform the skill set that is necessary, because it is so important.
Yeah, because if you look then at the well-executed trial, even in imaging, we have these experts who have done the clinical trials and who have created the evidence. Then later, all the experts will do it, and they are not all experts. So for patients, if they need a treatment like a focal therapy, which is experimental, the question for the patient is not what does the literature say on erectile dysfunction or incontinence. No, what are your results, doctor? I want you to treat me, but what are your results? Still knowing that not everything, he is not a statistic. He is one case, but he wants to know his odds. And if the clinician has to say 4 and 5 have no problems with me, that is better than what the literature says. But he also says 1 in 5 may still say, with me as an expert. So it's important to bring the information on a to patient level.
That is a great point. Karim, please.
Yeah, and I was going to jump on the point Dr. Briers made, is this clinically integrated trial has very minimal inclusion criteria because it's
pragmatic.
part of your routine practice. There's one specific surgical question that you want to know, and that allows with that. The other thing is, instead of randomizing patients, we cluster randomize the surgeons.
Yeah.
You don't know what's good. Your starting point as an investigator and surgeon is, I really don't know if intervention A or intervention B is better.
Absolutely.
So these 3 months, you're going to do intervention A. In the next 3 months, we will randomize you to, it could be an intervention B. And you disclose that with the patients. And at the end of the day, because in the relationship with the patients, you always have to tell them that I will always do what I think is best for you.
Yes.
But if I am in a position where I don't know what I think is best, then I will follow the randomization assignment.
I see.
And I think that's how this
and this is
pragmatic trial is.
This is what you
built.
did, right?
Yeah,
you
exactly what
randomized
we did.
surgeons to specific treatment,
Right.
extended versus limited, and the results were absolutely in favor of extended lymph node dissection, as long as metastasis-free survival was considered as an endpoint.
Right.
Is that correct?
That's absolutely what we found. And I can tell you the primary endpoint of the trial was difference in biochemical recurrence. We did not find a difference in biochemical recurrence. And this is an update of the trial, sort of. We didn't give up on the analysis. We said, let's wait a little bit and see for different hard endpoints looking at metastases. We looked at any metastases and distant metastases. And we found that when you do an extended pelvic lymph node dissection, you reduce the incidence of metastases in those patients, any metastases and distant metastases. Then there is, because it's a secondary endpoint, you always worry about multi-testing.
Yes.
But the p-value is less than 0.001, and the hazard ratio in a subset of the patients was 0.49. So certainly it's a robust, it stands sort of the test of statistical veracity.
Let me just ask you one thing, and then we'll talk about another topic, which anyway it is integrated with that, which is imaging and the possibility to rule out metastasis up front. What is maybe explanation you have within this trial with regards to the lack of any impact on BCR while there was an impact on metastasis-free survival?
Right.
What is the biological explanation, if any?
So I think the biological explanation is not an explanation, it's a question.
Okay.
So I think I end up with more homework to do, and sort of in a way it's interesting because it created a whole debate and questions for us to understand the biological mechanistics of metastases and how a surgical intervention or how a good local regional control can actually impact the biology. So that's the main question, and that's the homework we have. But in a way, what we did is we looked at difference in metastases from radical prostatectomy to metastases. We also look at it from the time of BCR to metastases, and we found also significant and similar impact of an extended lymph node dissection, which might suggest that these events are happening probably after BCR.
I see.
And in the biggest impact, what we found is in patients that have pathologically node-positive patients.
Yeah. No, that's makes sense in a way, because what we understood it, of course, those more suitable for extended dissection are those with adverse characteristics, right? Not those with more favorable features. And there has been a debate this morning about this guidelines release about different recommendation of PLND, but I don't want to go into that. I just want to integrate your results with the story of imaging and the integration of PSMA PET, for example, because using negative imaging, we might spare lymph node dissection, and using negative imaging in the recurrent setting, we might even think about intensification therapies. So in a way, what to do with the negative test? This is a great question. So Alicia, your experience and your idea on how to integrate PSMA PET in the recurrent setting and what to do in patients with a negative imaging.
Yeah, so I should say that we can talk about not using PSMA PET in a recurrent setting or using it, but we're all using it. So it's interesting that we've had multiple debates because it is fully rolled out. It is here, and in areas where it's not, it's coming up to speed. So the question is not should or should we not use it, because we simply are. But when we don't have a PSMA PET positive in a patient who's had a prostatectomy previously, still the standard of care is to radiate the pelvis and do salvage radiation. I think we still have questions, though radicals tried to answer them around the duration of ADT. And 2 years seems like an awfully long time, but that's the best data that we have right now for preventing metastases in these patients who are high risk in particular. When we have a PET positive area, we don't yet have data, but we're often using metastasis-directed therapy. I think in some areas we're using salvage radiation to the pelvis in addition to that metastasis-directed therapy. That's frequently what we do at our institution, but that's not ubiquitous either. And there are many places that they're simply doing a metastasis-directed approach. So there are so many questions around this. And when we have negative imaging and the pelvis has been maximally treated, we now have, for patients with high-risk biochemical recurrence, the EMBARK data, which tells us that we can intensify ADT with enzalutamide and prolong metastasis-free survival. And it looks like we will probably have an overall survival advantage in the end as well, though that data is not yet mature.
Karim, I'm getting back to you about the story of intensification therapy. So is there any chance that we might go back to the use of early intensification treatments after surgery, for example, in the truly adjuvant or perioperative setting? We are assisting towards earlier administration of intensified approaches. Does it make sense to use it or to go back to use it perioperatively or right after surgery?
I think it's going to come down to dividing biochemical recurrence setting into different risk groups, because then in that the disease doesn't behave the same way, yet we still give it one label of biochemical recurrence. I think we're going to identify either based on molecular signature, genomic profiling, preoperative characteristics of the disease, imaging, as Alicia spoke about, to say this patient is on a track for high propensity for developing progression of disease, and we should have intensification of disease. And other patients may have a disease that lingers in that setting for quite some time, and we could withhold that. Any intervention might, from trials, show a benefit. There's also some impact on quality of life. There's also that we can save or delay for patients that don't need to have it right away.
But Alicia, one question for you. When is it possible in a way to de-escalate therapy? So when would be allowed to, in a way, de-intensify this approach? Is there any possibility to test it, or do we have data on that?
Well, I think that, EMBARK really included patients with high-risk biochemical recurrence. These patients had short PSA doubling times, and this was really a very specific setting. I think we have natural history cohorts from Johns Hopkins as an example that show that there are patients who will have biochemical recurrence with a long PSA doubling time that can go years and years without ever developing metastatic disease. And if you only have PSA as the only sign of your disease, other than anxiety and the stress that causes you, there are no physical symptoms directly caused by that protein. I would love to hear your opinion. I think that anytime we can withhold ADT, and this is something we want to do, and even when we decide to use enzalutamide as a single agent, we are not leaving patients symptom-free. And in fact, gynecomastia and other complications are pretty common. We'd love to hear your thoughts.
No, that's true, because also in some cases you would go for lifelong ADT, and there will be trials just to see, can we give these patients a break? Because it's so important, because ADT is one of the worst things that happen to a patient. And if you put an RP on top of that, it's only becoming worse. So if we could give the patient a break, even if you say we give you a break for half a year, a number of them will regain quality of life, sexual life, which they lost due to the ADT treatment, because it's still chemical castration. We can call it differently and make it friendly. But I would also like to add something on the imaging in these. We should not forget, and it's an important aspect, that not all of our institutions and in all our countries, we have enough of the novel PSMA PET equipment. So they need to have also guidelines on how to do this PSA recurrence without having access to the novel modalities.
This is a great point. And many guidelines are also including these second line possibilities to use different alternatives in case there are no specific facilities, there are no specific resources to have that approach. So I think this is very important. And I think that patient voice is mandatory. especially because now we are even giving 3 therapies in patients with metastatic hormone-sensitive de novo prostate cancer. So do patients accept this kind of extra intensified approach, or is it something that you need to discuss? This is a question for you both. Is it something that in your practice is accepted by patients, provided they is fit enough to receive it?
You know, I think that truly comes down to a discussion with the patient. There are some patients, and I'm at a large academic center, there are patients who will travel to come for my opinion because they want to be more aggressive. In the spectrum of cancer control versus optimizing quality of life, so maximizing both on either end, many of the patients are towards the end of maximal cancer control. And in those situations, there are times that I have to talk them down from triplet therapy if they're not fit, if it's actually treating them really poorly and they're having significant complications. But there are patients who absolutely will say, I really want to optimize quality of life. And quality of life can be optimized, I think, from an ADT and ARPI type of an approach for many patients. I would say that the patients who are more of a slam dunk for triplet therapy are those de novo and high volume metastatic disease patients. But there are also patients in that group who now are also getting radiation to the prostate, which is quadruple therapy. Yeah. So we're intensifying over time even more. And from a patient perspective, I know that's a very personal decision in terms of treatment.
It is very personal because but you can drive a patient to accept them even a 5th line if you can convince him that it will be better. If, for instance, his priority is overall survival, then he might accept the 5th line. If you tell him and explain to him, you may have another 2 months. And sometimes that's relevant. Family things can make that the patient just goes for overall survival, a grandchild coming or something like that he wants to witness. But that is very personal, as you say, and this is shared decision making. You have to sit together and you have to weigh the benefits and the risks, because the basic risk comes from this ADT and on top of that RP. So sometimes adding something, like in the future perhaps lutetium, will not change much in his risk, but may change his benefit. And that's where we want to go then. If you add a 3rd or a 4th line, the safest possible and the smallest possible increase in the risk and his quality of life involvement.
Karim?
And I think in prostate cancer, we're on the brink, and every day we're coming closer to this precision and personalized medicine, and the liquid biopsy, the cell-free DNA, circulating tumor cells, is something that's coming so close to becoming part of our practice, both, and Alicia, you can attest to that, in response to therapy or selecting patients for escalation in therapy.
Yes, I completely agree. And it might also help us in de-escalating. So in the metastatic setting, there are trials going on to see if we can incorporate intermittent therapy, stop our treatments. And I think circulating tumor DNA, which is going to be more precise and more sensitive, I think, than PSA that's undetectable, will be one of the key factors that help us make those decisions.
Absolutely. What is, and this is my last question, because as a surgeon, I need to ask for your opinion about really, in this setting of locally advanced disease, we're not talking about metastatic now, we're talking about locally advanced. What is the role of surgery? Is a trial like yours useful to have more surgical trials, for example, in this setting? And what you believe can gain ourselves from a surgical trial that you planned and you executed?
I think from an evidence-based speaking, we still have to wait a little bit for the ongoing trials to truly put that. And so if I give you my personal belief on the concept, is I believe that local control is very important, or local regional control. And I believe that surgery is a major contributor in that setting.
Excellent. And from a patient perspective, whenever there is a shared decision-making process involving surgery, radiation therapy, or any kind of additional treatment, what is the real key factor? We do have 30 seconds and we need to close.
The real key factor for the patient is cancer control, overall survival. If you tell them we will give you radiation treatment, but it's a little less or little this or little that, then he may swing over. But on the lymph node dissection, we are going to switch, because in the guidelines we always said extended lymph node dissection is needed for stratification only. But now we are learning that it's much more, and that there's a clinical benefit. So
Well, we need to be very cautious here
I
because
know,
the trial is not
we're
yet published.
waiting.
And we need to evaluate it, and the guidance actually gave different recommendations this year as compared to previous years.
Yes.
In terms of reducing the need for lymph node dissection in
Yes.
prostate cancer. But this is another topic
We wait
may
for the
speak,
evidence.
and we may speak about this for hours. So thank you very much. It has been a true pleasure for me to host you, and I wish you a nice continuation of the meeting. I hope to see you soon
Thank you for having
somewhere
us.
around the world. Thank you.
Thank you.
Thank
for having
you.
us.